Hello, I'm Dr. Giulio Falasconi. The study I will talk about is a study conducted at Tecnon Medical Center, Barcelona, Spain, by the research group of Dr. Antonio Berrueso, of which I'm a member. The name of the trial is QDOT-by-LAWT trial. The PVI, the pulmonary vein isolation, is the cornerstone of atrial fibrillation ablation, paroxysmal atrial fibrillation ablation, and the very high power short duration ablation is an ablation mode that proved to be safe and effective. However, anatomopathological studies reported that the mean lesion depth of very high power short duration ablation is around 3.5 millimeters, and the left atrial wall thickness of patient with paroxysmal atrial fibrillation ranges from 0.5 millimeter to 4.5 millimeter. So that then very high power ablation only may not be sufficient to be transmural in all atrial left atrium regions. So that multi-detector computer tomography derived left atrial wall thickness map could be useful, could be imported into the navigation system, and could let us to be aware to the local left atrial wall thickness, so to switch from a very high power short duration ablation mode to a standard power radiofrequency ablation mode during the ablation. So this trial sought to investigate the safety, the efficacy, and the efficiency of a left atrial wall thickness guided ablation protocol combining very high power short duration and standard power radiofrequency ablation in paroxysmal atrial fibrillation ablation. We included 162 patients with paroxysmal atrial fibrillation. They were prospectively enrolled and randomized on a one-to-one based to the study group, QDOT-by-LAWT, and to the control group, close. They are all patients with paroxysmal atrial fibrillation and not responding to at least one antiarrhythmic drug. The exclusion criteria were age less than 18, moreover, previous atrial fibrillation ablation, the impossibility to perform a pre-procedural multi-detector computer tomography, or an contraindication to general anesthesia. The QDOT-by-LAWT group, in the QDOT-by-LAWT group, the ablation mode depends on the local left atrial wall thickness, so that for segments with left atrial wall thickness less than 2.5 millimeters, very high power short duration ablation mode was performed, while for segments of left atrium with wall thickness greater than 2.5 millimeters, standard power radiofrequency ablation mode was performed. In the standard power radiofrequency ablation mode, ablation index was titrated according to the local left atrial wall thickness. In the control group, the closed group, left atrial wall thickness ablation was not, left atrial wall thickness information was not available to the operator, so that the ablation settings were the ablation setting of the closed protocol. An ablation index of greater than 400 for posterior wall and greater of 550 for anterior wall. And so this is the differences between the two groups of the study. In the QDOT-by-LAWT group the QDOT-by-LAWT arm reported a significant reduction in procedure time, reporting a median procedure time of 40 minutes versus 70 minutes in the closed group, a significant reduction in the radiofrequency time, reporting 6 minutes of radiofrequency time versus 25 minutes in the closed group, and reporting a significant reduction in the fluoroscopy time. Moreover, there weren't significant differences in hospital complication rate and between the groups, and there were significant differences in the pulmonary vein, first pass pulmonary vein isolation rate in left pulmonary vein and right pulmonary vein. At log rank analysis at 12 months follow-up, there were reported no significant difference in the atrial arrhythmia-free survival. reporting an atrial arrhythmia-free survival around 85% for both groups. The take-home message is a first trial reporting the 12 months outcome, comparing the 12-month outcome between a very high-power ablation approach and the standard of care closed control group. And moreover, this is the first trial reporting the feasibility of a left atrial wall thickness guided approach, combining very high power ablation mode, very high power short duration ablation mode for the thin segments, and standard power radiofrequency ablation in the thick segments of the left atrium. Moreover, it was reported that the QDOT-by-LAWT arm is not inferior in terms of atrial arrhythmia recurrence-free survival at 12 months follow-up, but reported a significant reduction in procedure, radiofrequency, and fluoroscopy time. More recently, more and more EP labs reported that they are adapting the closed protocol utilizing high power settings, so that further study could be a comparison between the proposed QDOT-by-LAWT arm and high power setting for PVI in patients with paroxysmal atrial fibrillation. And moreover, the high efficiency reported by the trial could open the door to a comparison between the QDOT-by-LAWT approach and single-shot approaches for PVI ablation of paroxysmal atrial fibrillation.